Thank you for that introduction, Dr. Soumya. And as you rightly pointed out, we are right at the you know middle of our certification program, and I'm very happy that we have reached this level. Essentially, thanks to all of you at AFPI, and without this, I wouldn't have had the kind of push and discipline that is required to really run a program. So going forward, like Dr. Samya was saying, we've had until now it has been more about orientation to terminology, orientation to hematologic diagnosis. And now we are at a stage today where we will talk about two highest levels of hematology treatments. One of them is stem cell transplantation, and the second is what is called as CAR T cell therapy. Now, both of these, in fact, when I was preparing to get in post MD, figuring out what super specialization I should do, I thought I'll do oncology because it was upcoming and nobody else was taking it. And in my mind, what we should be doing is we should be learning something that will peak a specialty that will peak when you are ready and mature to manage it. So when I was finishing my MD in 2004, cardiology was, of course, ruling the roost, and everything else was after that. Meanwhile, I didn't get into the first entrance in oncology, and then I joined as an SR at CMC Vellore in hematology because I thought, hey, let me see what this is. This is a new specialty. After I worked there and we saw the level of work which was happening, especially the bone marrow transplantation, as we used to call it that time, and I realized that this is the pinnacle of treatment in oncology, hematology, and I decided to chase it. I spent a significant part of my time going through education. I spent almost 8, 9 years learning hematology, bone marrow transplant, just that specialty before starting my first job. And it has been very exciting. It's very exciting because hematology, oncology, transplantation are new specialties, and hence they're very rapidly evolving, rapidly changing. And 2004, when I went to CMC Vellore till now, it's almost 20 years now. Well, over 20 years. And the way we do transplants has almost completely changed in 20 years. So truly, this is the most complex treatment that we do. And in the last few years, there's been this whole noise about CAR T cell therapy and how CAR T cell therapy is the next best thing for cancers, etc. So let us see what are these, and let us see if we can get a conceptual understanding of both of these treatment modalities. So that's the overview, what I just told you. And now we will first look at the terminology. What we used to call as bone marrow transplantation, that name was given because initially it was thought that, like somebody's liver fails, you take another human being's liver and put it in your patient. So you actually take the organ and you put it in. Same thing for kidney. And it was thought that, the initial first few patients who had bone marrow aplasia because of the chemicals and the radiation in World War II. And with these chemicals and radiation, the bone marrow becomes completely killed off. It's aplastic. So what some physicians tried is they tried taking a needle, putting it into another person's bone, aspirating the marrow, and then putting it back into the bone of the affected patient, the aplastic anemia patient, right? So you actually take the bone marrow from one person's bone and inject it into the bone of your patient, the recipient. And that is why the treatment was called bone marrow transplant. However, as time went by, we realized that in the marrow, there are a lot of cells, there are a lot of progenitor cells, as we have repeatedly discussed during this lecture series. It's a factory. But the factory is created by a seed, a stem cell. And this seed creates the entire factory, and the factory then creates all the RBCs, WBCs, and platelets. That's what actually happens. So the question essentially is, do we really need to replace the entire marrow, take it from one person donor and give it to the recipient? Or what if we just take these stem cells? And it was understood that just the seed is enough, just the stem cell is enough. And that is where the terminology changed from bone marrow to stem cell transplant. However, mind you, there are different kinds of stem cells in our body. So we have neurogenic stem cells, we have something for the muscle, we have different kinds of stem cells in the GI epithelium, etc., etc. Hematopoietic system. So we are interested in that stem cell which can create the marrow, the hematopoietic system. We are not interested in other stem cells. So this is the most accurate terminology. HSCT, hematopoietic stem cell transplantation. All right. So today, when we talk to patients or other doctors, we call it either SCT or HSCT, one of these two. They are the accurate ones. When we collect the stem cells, we can of course collect them from the marrow because marrow has stem cells, right? It's the treasury of stem cells. However, what we have also learned is these stem cells, some of them escape out of the marrow and they float around in the blood. So you can even get stem cell from peripheral blood, although they're very less in number. And we have to give growth factor injections for 5 days for the marrow, for the stem cells in the marrow to multiply and then come out in the blood in enough numbers for us to collect them so that we have enough cells for transplant. So when we collect stem cells from the peripheral blood, the treatment is called PBSCT, peripheral blood stem cell transplant. So we can collect these cells from marrow, then it's called BMT. If we collect from peripheral blood, we call it PBSCT. And we can also get hematopoietic stem cells in the umbilical cord blood. Now, this is fascinating. The placenta and the umbilical cord are just amazing organs. And the umbilical cord blood, although it is of very small quantity, 100, 110 ml, it is rich in hematopoietic stem cells. So when a baby is born, normally the placenta and the cord is thrown away, right? And the instead of doing that, if we just release the clamp on the umbilical cord and let the umbilical cord blood get collected in a container and store it appropriately, that has enough stem cells to do transplant, especially in children. It may not have enough for adult transplants. But the way we understand today, we can get stem cells from marrow, blood, and umbilical cord. But who will give these stem cells, right? And based on that, there is some more terminology. In some diseases, lymphoma and myeloma specifically, the patient himself or herself can donate stem cells, their own stem cells. Okay. And this is called as an autologous stem cell transplant. But majority of the diseases, we need a donor. We need someone else who has an HLA match, HLA, human leukocyte antigen. Okay. This is called as typing. So for blood transfusion, we need to match ABO and RH blood group. For stem cell transplantation, blood group is not that essential. What is essential is matching the HLA. Okay. So what we do is we take a blood sample or a buccal swab of the patient, parents, brothers, sister, children, and send it to the lab. In the lab, they will do HLA testing of the patient and the family, and we try to see if we are able to get a match. Rarely, once in a hematologist or transplant physician's career, there is a patient who has an identical twin. Now, identical twins have identical face and voice and color and hair and height and also identical HLA. So if you're fortunate enough to have a patient who has an identical twin, then you can do HLA, confirm that they are identical, and do what is called as a syngeneic stem cell transplant because they are similar in genetics, right? But most of our patients, like I said, don't have identical twins. So we do this HLA test on the blood or buccal swab of the family, and that's a a related donor stem cell transplant. Um, when just a minute. Now, when we do this HLA test, if the relative, brother, sister, father, mother, is a full HLA match, okay, then we call it a fully matched related donor transplant. However, the chance of getting a full match in our ethnicity in India is about 30% with siblings and 3% only with parents. So only 3% of people in our community are full HLA match with parents or their children. So across the generation. But there is a 33% chance, 1 in 3, or 25 to 30% chance that I will be a full HLA match with my sister. Now, what do you mean by full? What we mean by full is when we do the HLA test, there are 5 antigens that we look for. So there is HLA-A, HLA-B, HLA-C, DR, and DQ. Okay, which means there are 5 proteins. So HLA-A, HLA-B, HLA-C, HLA-DR, and HLA-DQ. I get 5 antigens from my father. I get 5 antigens from my mother. Similarly, my sister also gets 5 and 5 antigens. So I have a total of 10 and my sister has 10 antigens. Now, out of these 10 antigens, suppose HLA-A, me and my sister are identical, and B is identical, and C not identical, D, E. So based on 10, we see how many HLA antigens are matching. Is it 1 by 10, 2 by 10, 5 by 10, 10 by 10, whatever it is. So when all 10 by 10 antigens are matching, we call it full match HLA transplant. However, like I said, most of the patients, we are not going to get a full match. And we today understand in the last 10 years that even if we have 50% match, so 5 out of 10, 50% match, 5 out of 10 antigens are matching, which is called as haploidentical. That's good enough. In most of the diseases today, the success rate of haploidentical is equal or even better than full match transplant, and we'll come to that later. In spite of that, there'll be some families where they don't even have a half match, haplo match transplant. At that point, what we do is there are organizations, there are registries in the world. They are called as unrelated donor registry, unrelated stem cell donor registry. What they do is they will go to offices and colleges and encourage people to register as a stem cell donor. Just register, okay? In that registration, they'll make us fill a form, and I am registered as a donor. So if my HLA matches with one of my patients, I'm so proud to donate my stem cells. And that can be done easily because it's not a surgery. I'm taking stem cells from the blood or the marrow. I'm not losing an organ. So when I enrolled as a unrelated donor, I filled up a form with my details, phone number, blah, blah, blah. They took a buccal swab and they did my HLA typing. So my HLA is on their software database. Every day, such unrelated donor registries get hundreds of emails from around the world. And there are millions of donors like myself who have pledged to donate stem cells. So we send an email saying, hey, I have a patient, this is the age, this is the gender, acute leukemia, I want to do a transplant. Can you look in your registry? So they take my patient's HLA report, type in their software, and they give a report saying, yes, we have a 45-year-old lady in New York who's by chance a full HLA match with your patient. Would you like her stem cells? Right? And there is another one who's a 90% match, another one who's an 80% match. So we see, okay, great. Let's why don't you ask that lady if she's willing to donate? Then the registry will call her and say, hey, you remember you had pledged to be a stem cell donor. Now there is a 27-year-old patient in India, in Bangalore, who needs your stem cell and you're a full match. Do you want to donate and save his life? Then that lady will think about it, talk to family, and usually come back and say, yeah, I would like to donate stem cells. So when we collect stem cells from such an unrelated individual, that is called as a voluntary unrelated donor transplant, VUD, or matched unrelated. She's an HLA match. You have to have an HLA match matched unrelated donor transplant. The word voluntary is important because money cannot exchange hands. In fact, the identity of the patient and the identity of the donor is coded. So my patient's name would not be revealed. It would be said donor patient number 187BCEH. And similarly, the donor would be a number, right? And the stem cells are harvested and transplant is done. And if everything goes well, if the transplant is successful, then 1 year after transplant, if they want, the patient and donor can meet each other, right? So this is the amazing part of stem cell donation. Now, once you have identified, okay, this is a patient who needs a hematopoietic stem cell transplant, needs an allogenic transplant, blah, blah, blah. We have identified the donor, HLA is matching, the donor is healthy. So ensure that the patient and the donor go through a very thorough health checkup, right? You look at the organ systems, you do blood tests, you do HIV, hepatitis B, VDRL, blah, blah, blah. You take consent, and then you say, all right, the donor is fit and the recipient is also fit to go ahead with transplant. Okay. Then we collect the stem cells. I told you we can collect stem cells from bone marrow, peripheral blood, umbilical cord. Umbilical cord is very simple. The umbilical cord blood is stored in a bag and frozen. So you have to just take that bag and give the infusion. However, when we are collecting stem cells from marrow, bone marrow, it is done like this. So you can see there is an operation theater. That's the donor lying prone under general anesthesia, because you see this is a painful procedure. So we put the donor under general anesthesia. This is one transplant physician. This is another transplant physician. We take the usual bone marrow biopsy needle, the same Jamshidi needle that you use for bone marrow aspirate biopsy. This is a posterior superior iliac spine on the right. That's the posterior superior iliac spine on the left. So on both sides, we put in the needle, right? We connect a syringe and we aspirate bone marrow. It's just like we aspirate for bone marrow examination. And we aspirate 2 ml, 3 ml, 5 ml, and we then give this syringe to the nurse. The nurse will put the marrow in a bag with anticoagulant. Then I take another syringe, I take some more marrow. So like that, we take 2, 3, 4 times we take marrow, then we remove the needle, we go to another point in the spine, in the PSIS, iliac crest, and take 3, 4, 5 times pulls, again give to the, every time you take a pull, we give it to the nurse, she puts it in the bag. So the whole thing goes on for about 1.5 hours. We collect about half to 1 liter of marrow, half to 1 liter. And that depends on the difference in size between the donor and the recipient. So suppose the donor is a young child, 30 kg, but the recipient is a father who is 60 kg. So we need more stem cells, because stem cells are counted as per the weight of the recipient, right? We need a minimum of 3 million CD34 cells per kg body weight. So somebody is 60 kg, the recipient, we need 3 into 60, that is 160 million CD34 cells, right? CD34 is a marker for hematopoietic progenitor cell. So this is how we collect the bone marrow. And it's a very simple procedure. We actually admit just for a day. After GA, half an hour, 1 hour later, the donor wakes up. They have a sip of water, then some food, and the next morning we discharge them. They may get some pain in the back because of the punctures in the bone. For that, they need paracetamol for a day or two, but that's about it. However, we do this less than 10% of the time today. Today, we collect stem cells from the peripheral blood. More than 90% of all transplants happen like this. So you might have seen a machine like this in a blood bank near where you practice. This is called as an apheresis machine. And you might have gotten SDP, single donor platelet, right? They are made on this kind of machine. It's exactly the same machine. Excuse me, which is used to collect stem cells from the blood. So you can collect peripheral, platelets from the blood by apheresis. You can collect stem cells, you can collect RBCs, you can collect anything that you want, provided you put the correct kit here. You see this tubing here? that correct kit has to be put in. Now, peripheral blood stem cell harvest does not require general anesthesia, does not require operation theater. This is done in the blood bank. Excuse me. Sorry. Just recovering for an upper respiratory infection. So you can see the donor is lying comfortably in a couch. There is one needle in this hand with the tube going into the apheresis machine. There is a centrifuge. The centrifuge will spin this donor's blood. When we spin the blood, it separates into RBC, buffy coat, and plasma. From that buffy coat, it will selectively suck out stem cells, and the stem cells get collected into this bag, and all the remaining blood goes back. So this is a continuous process, somewhat like dialysis. Takes about 4 hours. The donor is fine, comfortable, watching YouTube on their phone. And after 4 or 5 hours, the stem cell looks like this. It's like dilute blood. You see, this is the buffy coat, concentrated stem cells with some platelets also. There may be some red cell contamination, but this is how the peripheral blood stem cell bag harvest looks like. We then take a little bit of sample from this and send it for flow cytometry. And in the lab with flow cytometry, we will get a report as to how many CD34 positive cells are there. If they tell us, look, there are 2000 CD34 positive cells per microliter, then I multiply it by the volume and I get to know how many million CD34 cells are there in this patient's harvest. Is it enough? Do I have at least 3 million, 2 to 3 million per kg? Then I say, okay, great, I have enough harvest. And generally in one day we get good harvest. So depending on whether you take stem cells from marrow or peripheral blood or umbilical cord, there are various benefits and there are different problems. And I'm not going to get into the details of this, but each one of them has certain purpose. Now let us see, when do we do stem cell transplantation? Okay, we have allogenic here and autologous on the other side. Allogenic transplant, for these conditions, it's very easy to understand, right? These are the patients in whom bone marrow does not work properly. So either there is thalassemia or sickle. So RBCs, hemoglobin production is not proper, or they may have primary immunodeficiency syndromes. So the WBCs don't work, or the entire marrow has failed, as in aplastic anemia. In these patients, it's very easy to understand, right? The marrow not working, take stem cells from a donor, put them in, it may create a new marrow and cure your patient. So this indication for SCT is very easy to understand. Okay. Next indication, cancers which cannot be cured by chemo or immunotherapy. So there are certain leukemia, lymphoma patients, and rarely myeloma as well, but a lot of leukemia patients who have bad genomics, who have not had a good response to chemotherapy or immunotherapy. And then you think, hey, look, just this giving this chemo immunotherapy is not going to cure. The chances of cure are very less. So what do? We will change your marrow. We'll change your marrow. We will take stem cells from another HLA matched donor, and those stem cells will go in to your body, into the bones. They'll create a new marrow. The new marrow will create new WBCs. So new immunity. New immunity. Now, this is a very important concept. You see, cancer, one of the theories of cancer is cancer happens when, because the patient's immunity fails to kill off the cancer cell. Okay, the patient's immunity has failed to kill off the first few cancer cells. So then they multiplied and created a full cancer. The analogy that I look at is that cancer cell is like a terrorist. And if the police, that is the immunity, if the police fail to identify them and kill them in time, if the police fail to identify them and kill them in time, then the terrorist, one terrorist becomes 2, 4, 16, 64, 100, thousands and lakhs of terrorists will be created. Similarly, the patient's immunity fails to catch the first few cancer cells and kill them. So then they multiply and create leukemia. Now, these are the patients, in some of them, when we see that no chemotherapy or immunotherapy is not going to cure, then we think, all right, it means that the chance of relapse is very high. That means even if we give chemo and immunotherapy, the cancer will go down and it can come back. It can come back. And if it is going to come back in this patient, we know the last time his or her immunity was not able to identify it, was not able to identify and kill it in time. Now, if relapse happens, it won't work. We have to change the immunity. So that's where we do an allogenic stem cell transplant. We change the marrow, change the immunity, hoping, hoping that the new immunity will be able to identify leukemia, lymphoma relapse early and kill it. This is called as graft versus leukemia effect. The bone marrow graft, the stem cell graft, graft versus lymphoma effect, graft versus malignancy effect, right? So these are the two major indications for allogenic transplant: marrow not working and some kind of blood cancer which you feel you have to change the immunity to prevent relapse. What about autologous? In autologous, we are taking the patient's own stem cells. So we are not changing immunity. What exactly are we doing? Autologous transplant is also done in some cancers like myeloma, lymphoma. It is done in some cancers for patients with testicular tumor, neuroblastoma. Now, these are cancers where they are supposed to be chemosensitive. Chemosensitive. What that means is, today, if I have a new patient with myeloma, if I have a new patient with myeloma, and suppose that patient has so many cancer cells in the body, bad cells, I give the first cycle of chemo and second cycle and third cycle and fourth cycle and fifth cycle and sixth cycle. Okay. But I know the chemo is not going to kill all the patients. So sooner or later, in about average of 2 years, this myeloma is going to relapse. Yeah. It has responded to chemo, but there are some cells which are left and they will then multiply and grow back after 2, 3 years. Average is 2 years. So then the question is, what if I give very high dose chemo and try to kill as many cells as possible? Very high dose chemo and kill as many bad cells, cancer cells as possible. So even with that, even if the relapse happens, it will happen a bit late. It will happen after 4, 5, 6 years, right? However, we know that chemotherapy is toxic. We know that chemotherapy has side effects: vomiting, hair loss, mucositis, oral ulcers, but it can also have life-threatening side effects. Chemotherapy is usually not targeted. It is not targeted. Chemotherapy will kill any cell which is multiplying. It may be cells in the hair follicle, in the oral mucosa, bone marrow, or cancer cell. Cancer cell is proliferating and multiplied fast. So any cell in the body which is rapidly multiplying will eat up chemotherapy and die. So if I am giving chemo to kill myeloma or lymphoma cell or neuroblastoma cell, at the same time, it will also kill the bone marrow, the good normal bone marrow, right? So if I give very high dose chemo, the patient will die of bone marrow failure, will die of infections, correct? So in autologous transplant, what we do is, once we have good control on the disease, we collect the patient's own stem cells, peripheral blood harvest, and we keep them in the blood bank fridge. So we take the patient's own stem cells and keep them. And then we give them very high doses of chemotherapy to kill as many cells as possible. Very high dose chemotherapy. Okay. This very high dose chemotherapy will then hopefully kill maximum cells, but then it's also going to kill the marrow. And to avoid the patient dying from damaged marrow, once the chemo is over, 24 hours later, we give back the patient's own stem cells. We give back the patient's own stem cells. Their own stem cells will go and they will help the marrow recover within 2, 3 weeks. So, autologous transplant is done to save the patient, protect the patient from life-threatening side effects of high-dose chemo. The transplant by itself does not kill cancer in autologous. Okay, it only helps the marrow recover from side effects of high dose chemo. And lastly, autologous transplant is also done in some very severe autoimmune diseases. Now, these are autoimmune diseases which are life threatening, bad morbidity and mortality, multiple sclerosis, systemic sclerosis, right? In these patients, when we take out the stem cells, give chemo, kill off all the immune cells, and put in the stem cells, make new marrow, new immunity, you're resetting the immunity. It's like rebooting your computer. You're resetting the immunity to a pediatric level as the patient was when they were born. That is the second indication for autologous transplant using the patient's own stem cells. So these are the indications for transplant: to replace a marrow which is not working, to create new immunity, to save the patient from life-threatening side effects of high-dose chemo, and to reset the immunity in certain diseases. Now let us look at the stages of transplant. Okay. So the day of transplant, the day when the stem cells are given, is called day zero. It's like a new birth date. Yeah. And before this, we have a countdown. We have a countdown. So day -7, -6, -5, -4, -3, -2, -1, and day zero. And after transplant is day +1, day +2, day +3. Even when I see a patient after 1 year, I'll write +1 year, 2 months, 11 days post-transplant, right? So that's plus. Before that, it's minus. Now, this 1 week before transplant, 1 week before transplant, we give high-dose chemo. Some patients will also give a total body irradiation, head to toe radiation. This high-dose chemo and radiation is called conditioning regimen. Conditioning regimen. This is given to kill off the original marrow. We have to kill off the original marrow, the native marrow. You cannot enter a house until the old tenants have gone. So we have to make the marrow, the bones empty. Okay. Then we generally give a 1 day gap, 24-hour gap. And the stem cells, you remember, which we had collected and we had stored in the blood bank. We give these stem cells to the patient intravenously, no surgery. Stem cells are collected from the blood, given by a central line, like a blood transfusion. Stem cells go in the blood. They will circulate in the whole body and they will sit in different bones. The beauty of a stem cell is it can find its own home. Even the scientific term is homing. The stem cells which will be given intravenously will float in the blood and will find its own home and sit in different bones and slowly start making a new bone marrow. However, the new bone marrow takes about 2 to 3 weeks. And meanwhile, we have killed off the old marrow. So there is going to be low hemoglobin, low WBC, low platelets, pancytopenia, right? We've killed off the old factory. Hemoglobin, not a problem, goes below 8. Every patient requires 4 or 5 units of packed red cell. Platelets will go to 0 practically. So we give platelets every day, every alternate day. WBC is going down, neutrophils literally going to 0. WBCs will be 0, 100 or 150 will be the total WBC count, which means that this is a patient who does not have any immunity left, right? The old WBCs are gone. When there is no immunity, it's like you've taken off the police, you've taken off the military. At that point, there will be criminals living in your neighborhood, your gut bacteria, commensals, right? Skin bacteria, gram positives, commensals in the respiratory tract, including fungi, aspergillus and candida oral. All of your commensals, which are the criminals living within the society, will become active because the police and military are not there. Also, criminals from outside will start attacking. So our patient can get infection from food, water, air, nurses' hands if they don't wash hands, right? I have an upper respiratory tract. Yesterday, I did not go into my BMT unit because I will give infection to my patient. So bugs from within and from outside can cause an infection. And that's the most critical part, febrile neutropenia, zero immunity. Our patients can go from being stable to being dead in 6 hours. So you have to have very rigid protocols for fever, culture, multiplex PCR, antibiotics, etc., etc. In 2 to 3 weeks, about day 14, day 15, we slowly start seeing the WBC coming up. The WBCs go from being 100 to 200 to 500, 800,000, 2,000, 5,000, 10,000. Platelets go from 5,000, 10,000, 20, 30, 50, 1 lakh, 2 lakh. That tells us, okay, the new marrow has now formed and it is working. When the neutrophils and platelets go a particular level, above a particular level, we know that the new stem cells have engrafted. They have created a new marrow. That is called engraftment. When this happens, the patient is kind of now safe from infections. New WBCs are being formed. Correct? However, however, that is fine in an autologous transplant. Their own stem cells, their own new WBC are back. However, in an allogenic, they are new WBCs. These new WBCs have not seen this new body before, and they will understand this is not my body. And the new WBCs will attack the body, right? WBCs are, after all, police and military. Their job is, if I see something that is foreign, I have to attack it. That complication is called GVHD, graft versus host disease. Graft versus host disease. If it happens in the first 100 days, we call it acute. If it happens after 100 days, we call it chronic GVHD. They're both different. I mean, even the 100-day is not that rigid. It's just that the clinical features of acute and chronic GVHD are different, and we will get into that sometime later. So you have to ensure that the cells which go in are matched. You have to try and prevent GVHD. You have to try and prevent and treat infections, right? And then gradually the patient stabilizes. And the new marrow, the new immunity will mature. So we have rebooted and created new immunity. This is a new immunity which has not seen infections. This is like the immunity of a newborn child. And in a newborn child, for the first 3, 4, 5 years of age, they'll have cough and cold and loose motions. Similarly, our patients go through these routine infections, right? Until the immunity matures. It takes about a year, 6 months to 1 year for immunity to mature. However, all the vaccines which have been given in childhood and adulthood, COVID vaccine, DTP, and all that, DPT, everything is gone. The entire immunologic memory is wiped out. It's like you're, reinstalling a new software on your laptop. So, post transplant, about 6 months after transplant, we have to again give all the childhood vaccines. So, we give DTP, oral polio, we avoid because it's live polio and immunity is a bit down. So, we give IPV, injectable polio. Okay, diphtheria, tetanus, pertussis, hepatitis B, MMR, pneumococcal. We give all the vaccines again. We also give COVID vaccine. We used to give when, COVID vaccine was a major issue. COVID was a major issue. So this is kind of the journey of a stem cell transplant patient. And for some time, they remain susceptible to some infections, especially CMV, cytomegalovirus, and we monitor the patient, So these are the common complications. Like I said, they're severely neutropenic, and we have to keep them in a bone marrow transplant unit where the air is HEPA filtered. Nobody can go inside without the nurse's permission. The food is boiled, the water is boiled, the food is microwaved. There are very strict protocols for hand hygiene, infection control, infection treatment. Only cooked food is allowed. We give a low bacterial diet, right? Because it can cause infection. We monitor for common infections, and every department has its own protocol. We have a protocol called Maggie. I call it Maggie protocol. And this has really helped us bring down the mortality due to neutropenic infections. I call it Maggie so that it's easy to remember for my team. I use multiplex PCR to identify the bacteria. We ensure that we are giving the right antibiotic, considering that most of the bugs in our country are even meropenem resistant, carbapenem resistant. We give growth factors. We give granulocyte transfusion. That's WBC transfusion. If there is any suggestion of infection of the IV line, we remove it early. We shift to ICU early if the patient deteriorates. Early transfer, proper coordination with the ICU team, and all of this helps us in reducing the mortality. Other complications, well, we are giving conditioning regimen, we are giving high dose chemo and radiation. So, all rapidly dividing cells are going to die. They're going to be oral ulcers, diarrhea. 100% of patients will get some mucositis, but that's fine. It heals in about 2, 3 weeks. You have to take care of nutrition in the between. In allogenic transplant, about 5 to 15% of recipients' bodies may reject the donor cells. So the new marrow may not form. But today it is much less. It's actually less than 10%. Then, of course, I told you, if the new stem cells are not rejected, they form a new marrow, new WBC, and they can actually attack the host. It's the opposite of rejection. So rejection is the recipient is killing off the incoming CD34 cells. And GVHD is the new CD34 cells are now attacking the host. Graft versus host, I told you, it happens in about half of our patients. We give good prophylaxis, and today there are fantastic medicines available for patients who get GVHD. So in half we can prevent, in the other half they will get it and they need treatment. But 90% of our patients we are able to manage it. However, 10% of patients GVHD can be life threatening. So what's the overall success rate of transplant, right? And how many patients actually die? In autologous transplant, truly nobody should die. If autologous transplant patients are dying, then something is wrong with that transplant department. In allogenic, about 10 to 30% of patients, depending on their age, comorbidities, and all that, may not survive, but majority do. And we have to ensure that the patient is fit and curable. We have to counsel the family. If it's a bad cancer, and they say, no doctor, but you do transplant, but the chances of success are not there. We have to honestly tell them that, look, if it was my father, I would not transplant, because the chances of cure are really bad. So you have to really ensure that you're doing the right thing and you're not unnecessarily doing treatment, right, which is not good. So these teams and the teams and the protocols, how we select, how we prepare the patients for transplant, how we manage the complications, all of that helps to keep the death rate, the mortality at a minimum. On the whole, if you have an aplastic anemia or thalassemia patient who comes to you early, young patient comes to you early, no major problems, 80-85% of them will go home fine, cured. They take immunosuppression, they need immunosuppression for 6, 8 months, and there are no medicines after that. I have one patient of aplastic anemia. We had transplanted, I think, in 2005, 20 years ago. Young guy, he was about 21, 22 that time. He had come to us early, aplastic anemia. We transplanted him. And he came to me about 7, 8 years after transplant. And he said, Doctor, can you make me unfit for duty? So I said, why? You're doing well, you're not having any infections, no GVHD. You're not even on immunosuppression. Everything has been stopped. He said, no, doctor, I work for Indian Army and they're sending me to the Pakistan border now and I don't want to go. Can you make me unfit? I said, we did the transplant so that you can go back to your normal life, live your life, finish your education, do a job, marry, have children. If your normal life is something that you don't like, I really can't do much, right? So they become that fit and they go back to normal life. However, if it's a bad cancer, refractory leukemia, not responding to anything, elderly patient, elder now, by the way, in transplant, elder means more than 65, 70 years of age, okay? So up to 65, 70, we think you're young enough, you can have a transplant. The oldest transplant that I have done was on a 73-year-old man. Okay, so elderly, sick patients, comorbidities, etc., etc., the chance of cure may be only 10%. So truly, we have to understand. On an average, cure rates, I mean, success rate for stem cell transplant are 60%. I'm talking of allogenic. Our data, I'll show you, and these are all the factors on which success rate depends. We have created a total of 15 bone marrow transplant centers in the last 10, 11 years. And what I have done is, these were centers from across India and including in Tanzania. We did the first bone marrow transplant in East Africa. And this is an old analysis 1 or 2 years ago. For the last 11 centers, the number of transplants, the different types of transplants, and this is our success rate. Our mortality was, just about 27, 28%. So we were able to ensure that we have good success rate, even across multiple centers and multiple teams. So you need good teams, good protocols, good training, very passionate people to actually achieve this level of success. So that's about it for transplant. The next, we have CAR T today, but I think it will be too much to do both in one sitting. I don't know what you feel. If you want, I'll go ahead, but I think it will be too much. Maybe next Thursday we can do CAR T cell therapy, because that by itself is a very fascinating topic. What do you think? Any suggestions from anyone?
I think that is better,
Um,
sir. And we have to discuss some doubts also now.
Yeah, yeah, yeah.
yeah, I
So,
request participants to kindly, ensure your availability next Thursday so that we just don't do it for the sake of doing the topics. Sir is giving you time so that you can actually be familiar with all the concepts taught now, and then you can discuss, and then we can see if we can move ahead.
Yeah.
The
Please go
intent
ahead.
is that, yeah,
Feel free to
yeah,
ask your.
yeah. Please
sir,
feel
I have a
free to
question, sir.
ask questions. Yes, go ahead,
Go
sir.
ahead.
The bone marrow registry, what you mentioned, and you gave an example, matching donor is somewhere abroad.
Mhm.
So willing to, give, donate their stem cells. So their, travel and their accommodation and all these things, who is going to bear the cost?
Fantastic question. So, see, there are creating an unrelated donor is a very, very expensive undertaking, because what happens is the just a minute, I'll come to this. Yeah. So, what happens is that you have to do HLA testing for millions of patients. I mean, millions of normal people to ensure that you have you will get some matches. So it's very expensive. HLA testing is very, very expensive. Now every one individual's HLA test will cost, even if you're doing it at a no profit no loss, it will cost someone about 4 to 5 thousand rupees. Yeah. So with that kind of expense, somebody has to bear it. Now most of the registries are not for profit, right? And they have to maintain all of this. The main cost is just doing HLA typing for millions of people. That's the key thing. However, there is also a cost that once you decide that, yes, I'm going to, accept this donor. And can you guys see the PowerPoint now? It was not
Yes.
visible. Yeah, okay.
Yes, we
So
can
that
see, sir.
yeah, that I'm going to accept this donor, then the blood test and all that of the donor, then the harvesting the stem cells and transporting the stem cells, that's another cost. So the patient has to pay for this. Yeah. Now, different registries have different costs. The American registry, I think, is the most expensive. So, because everything is billed in dollars. Even when you do hemoglobin for the donor sitting in US is going to be in dollars. So that cost is about 10 lakhs. 10 to 15 lakhs almost. The German registry is amazing. It's a pure not-for-profit. I work very closely with them, and they many times reduce their cost from 8, 10 lakhs to 2, 3 lakhs, or sometimes even make it free for very poor patients. So all of that is there. From this, I'm going to address another issue is once you identify the donor, suppose our patient is in Bangalore and the donor is in Delhi or New York or Sydney. The donor never travels. Yeah. The donor stays in that city and there will be a bone marrow transplant center close to the donor where the workup is done, the stem cells are collected, and the stem cells are actually carried just how you will carry, red cells or platelets in a box. So the stem cells are carried by human courier. That means a person takes the stem cells and sits in the flight and actually brings the stem cells and over to the transplant center. And there we have started the chemo and we infuse the stem cells IV. Yeah. Any other question?
So once the patient receives a new stem cell and he has completely recovered, can he donate maybe after years for somebody?
Stem cells?
Yes, sir.
Of course, I've done two such transplant. Very interesting question. So there was a family, two families, of course. One family, both the children had thalassemia, and second family, both the children had immunodeficiency, leukocyte adhesion disorder (LAD). So we, the first child got an unrelated donor. Okay, and that unrelated donor was HLA matched with both the children, right? So rather than taking this unrelated donor stem cells twice, we first transplanted the first child, right? And 1.5 years later, when this child is absolutely stable, no problem, no GVHD infection, blah, 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 then we took stem cells from this child to the second child. Now remember, these stem cells belong to the donor, right? So yes, we've done that for one thalassemia family and one. I mean, I have done it for one thalassemia and one LAD family, but that's usually rare. I have another thalassemia family from Sri Lanka in whom we are planning this next year, maybe later this year. But very interesting question.
Sir, as primary care providers, when they come, first thing they ask is who is a good hematologist, and then when they visit and when you suggest a transplant for those whoever it is required, the next thing is they would want to discuss the cost. Can you
Yeah,
please give us an outline how
yeah,
we counsel the patient on cost?
yeah,
Because
yeah,
see, for everything and anything, family physicians are involved in the loop.
yeah. So autologous transplant. I told you that we do this for lymphoma and myeloma, right? Now, when we do it for myeloma, that's the cheapest transplant. In most of the hospitals, it will cost about 12 to 15 lakhs. We do it in 8 lakhs. That's because I'm the only doctor in entire Southeast Asia who does multiple myeloma stem cell transplant in daycare. We don't even admit the patient. Everyone in the developed world, so US, Canada, UK, New Zealand, Australia, everybody does myeloma transplant, autologous transplant on daycare. In Southeast Asia, nobody does. I've done a total of 8 patients and with 0 deaths, including one who had multiple sclerosis, autologous. So this indication. Those patients, the bill was only 2.5 lakhs. Can you believe it? And they had
Oh.
less infections when we did it on daycare. That means they would come in the morning, take chemo, go back. Next day, come, take stem cells, go back. Next day, come, take IV fluids, antibiotics, go back home. So we are not admitting them. We're sending them home, right? Of course, there are criteria. You can't do it for every patient. They have to have a house close by, intelligent, educated family, etc., etc. So multiple myeloma, autologous transplant, 12 to 15 lakhs. We do it in about 8 lakhs. Lymphoma, autologous about 15 lakhs. All the allogenic transplants, whether it is aplastic or thalassemia or leukemia, doctors in our country will say 17, 18 lakhs. The fact is everybody spends 25 to 30 lakhs. That's a fact. Every patient will have some complication and we need money to give antibiotics, immunosuppression, do tests, this test, that test, supportive care, ICU. If you don't have the funds, the mortality will be very, very high. Now, most of the hospitals and doctors in our country, unfortunately, try to say, no, no, we'll finish it in so much amount and all that. And then they'll say, no, but the bill has gone up, you had complications. We don't do that. So we tell them in the beginning, look, it's an allogenic transplant. It's going to cost you 25, 30 lakhs. First 1 month itself, the transplant period, you will spend about 15, 16. Then every month there'll be blood tests. Immunosuppression is about 1.5 lakh every month for 5, 6 months. So be ready with 25, 30 lakhs. What we do is we tell them the reality and we help them raise the money. We help them get free medicines. So what we do in my department is, we have pharma companies will tell them, hey, look, I mean, the major cost is cost of drugs, right? Medicines. We are a medical specialty. So antibiotics, immunosuppression, chemotherapy, IV fluid. So we get free antibiotics. We get free blood tests for levels. We do cyclosporin and tacrolimus levels to ensure that we are giving the right immunosuppressive dose and all that. So, we have tied up with pharma companies which sell tacrolimus, and they give about 4 levels, blood levels for free. We also use Chief Minister Fund, Prime Minister Fund, and crowdfunding. In fact, we are starting our own crowdfunding platform to help patients raise money. We have raised just over 2 crores in the last 5, 6 years. We've helped about 21, 22 patients. Somebody needs 2 lakhs, somebody needs 20 lakhs, right? They have nothing. But if the family is committed, my approach is rather than saying, no, no, we will try to finish in this much, we say, no, let's be ready with, a good amount and let's figure out how we are going to raise. So I think that's how we counsel. Uh, if I have enough examples, and all of you have enough examples, that if the family is committed, they will do whatever is required to raise money. And if the family is not committed, they'll say, no, doctor, can't be done. And we say, yeah, no problem, then don't do it. That's our approach. That's how our team works.
Okay. Thank you, sir. I just have
Sir,
another
sir,
question. How do you manage this autoimmunity during transplants, autologous transplants,
We don't get
especially
autoimmunity. It does.
autoimmune disorders like multiple sclerosis? You said you have
Oh,
done
how?
transplant.
So the transplant is the
Okay.
same. Basically, we give conditioning regimen that high dose chemo will wipe out the existing T cells, B cells, NK cells. It will kill off the memory B cells. And then you put in new stem cells, and the new stem cells in 3, 4 weeks make a new marrow, and that's it. Once your memory B cells and T cells and plasma cells are dead, there is no antibody formation. So
Correct. You would reduce the autoimmunity in the patient or reverse it?
if there has been permanent damage, so if there has been sclerosis, fibrosis can't be reversed, right? Now, I
Okay.
have a patient of multiple sclerosis in whom actually we did the daycare transplant. She didn't have any money. And so we transplanted earlier, she used to get relapse. It was relapsing remitting MS. And she used to get a relapse every 6 to 8 months. Now it's been almost 2 years plus, she's not had a relapse because there was one clone of autoimmune cell which was attacking the CNS. That clone was killed by the conditioning regimen. Same thing goes with systemic sclerosis, etc.
I think this is a
Dr.
very
Zahida,
new concept. Thank you,
yeah,
sir.
yeah, yeah. Dr.
sir,
Zahida,
good evening, sir. Good
yeah,
evening,
hi,
sir.
yeah.
Sir, I am basically a government medical officer, sir. Regarding in Karnataka, Ayushman Bharat Arogya Karnataka scheme, that will be covered for these poor patients and also.
Yes, so last month, bone marrow transplantation was included in Ayushman Bharat. Last month only,
Yes, sir. Thank you.
In the Karnataka scheme. It gives about 8, 10 lakhs, right?
Yes.
And that is perfect if I have to do a myeloma or lymphoma autologous transplant. But I discourage patients from doing allogenic transplant. I discourage because these are the poorest of the poor, right? I can admit these patients, suck off those 8, 10 lakhs and do a transplant, and there is a complication, and poor people don't have money for complication, and the patient will die. So, as a responsible transplant physician, if somebody is purely dependent on Ayushman Bharat, we should not transplant them. 70-80% of them will die because there'll be no money left for complications. But some doctors do that. There are other schemes. So CGHS, ECHS, these are very good schemes. In that, we certainly do transplants. Yeah. But I think it's just ethically incorrect to do complex allogenic purely on Ayushman Bharat and put the family in trouble.
Thank you, sir.
Suppose
Anybody
we
else?
have a HIV positive patient with, undetectable viral loads, who may require a transplant, allogenic. Is it possible, sir? What is the outcome? Because we are always worried when there is when immune system gets affected, may it be autoimmunity or may it be, uh, you know,
Yeah.
HIV positive status. So can you please comment, because we keep seeing a lot of HIV positive cases of late. We are also picking up many of them. That's where the concern. And also comment on HCV and hepatitis B as well. Thank you.
So I'll finish off HCV hepatitis B. Many times during the transplant or patients come to us with aplastic anemia, leukemia, they may not have received safe blood. Very rare today, but it still happens. And because of leukemia, aplastic anemia, they've received transfusions. They become hepatitis B and C positive. Now, in that, if it's an urgent transplant, we have to go ahead. We give whatever medications, so lamivudine, entecavir, etc., to keep the viral load under control and then go ahead with transplant. If it is not urgent, then we work with the GI and the hepatology team, bring the hepatitis under control, and then go ahead and transplant. So that's hepatitic viruses. HIV is a very fascinating disease. There are three important things that we have to talk of when we talk of HIV and stem cell transplant. In HIV patients, they may get a lymphoma, they may get a myeloma, they may get a leukemia, and you have to transplant them, right? Like any other patient. At that point, if the viral load is very low, if the CD4 count is good, then they are like any other patient. They don't have any additional complications. Okay. First. Second, there are HIV specific diseases like Burkitt lymphoma, yeah, which sometimes need autologous or allogeneic transplant. Even in that, the complications and outcome of lymphoma treatment with or without transplant is dependent on CD4 count, absolute CD4 count, and the viral load. So yes, if the viral load is fantastic, if CD4 count is good, they're like any other patient, whatever is the indication. Now, the third thing, which is a biologic curiosity, is, there are these rare case reports of patients who get exposed to HIV, but they don't get infected. Have you heard of those?
You mean they're in a window period we don't pick up, or?
No, they just don't get infected. You can give them as many HIV virions that as you want, but they will not get the infection. So,
Oh,
yeah.
unheard. We have
No,
not
no,
heard.
no, it's there, it's
Uh,
there. Sorry? Okay. So, the HIV virus, do you know what is the receptor for HIV virus? When the HIV virus selectively infects your macrophages and lymphocytes, right? It doesn't infect usually the other cells. There is a receptor. The receptor is CXCR4. CXCR4. So chemokine X receptor 4, CXCR4. There are a small bunch of people who genetically in the CXCR4 gene, they have a certain polymorphism So when that gene gives rise to RNA and RNA gives rise to amino acid and protein, and the CXCR4 molecule is formed, the quaternary structure. There are rare patients, handful of patients in the world, they have a polymorphism by which the CXCR4 receptor is such that HIV virus cannot get attached to it. And if it can't get attached, it can't go inside the cell. And if it can't go inside the cell, it can't multiply. Correct? So there was now I probably know this because the entire HIV epidemic started in our country, the recognition, when I was doing my MD. And all of these new concepts were coming up. And we used to debate this. And so theoretically, if I have a patient who is HIV, okay, positive, and not responding to antivirals for whatever reason, and if I have a donor who is not having HIV, of course, who has the CXCR4 gene, which makes his lymphocytes and macrophages resistant to viruses. And this donor is HLA matched. And then I do an allogenic transplant, then I now get new marrow, new immunity where the virus can't enter, and that patient could potentially get cured of HIV. If I'm not mistaken, there are two patients in the world who have gone through this. The first one happened by chance. The first one, the patient had an unrelated donor, and the unrelated donor by chance had a CXCR4 gene which was resistant, which made his or her cells resistant to viruses. And post-transplant, to the doctor's surprise, the viral load kept on going down, and they did not understand why. And that is when the CXCR4 gene of the donor was sequenced, and this was discovered. So in the German DKMS registry, every patient, okay, when they do the HLA, they do the CXCR4 genotype, and they have a group of patients, donors, sorry, who have the CXCR4 gene, which is resistant to HIV infection. And by chance, if one patient has HIV and has two donors, then they'll say, no, 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 take the second one. The second donor has a gene which is resistant to virus, HIV. So that's the beauty of biology, right?
Thank you, sir, for that interesting comment. We also have a question from Dr. Oliver. Is drug like OHA or antihypertensive a contraindication for transplant?
No, not at all. So
Okay.
you should all go to the website of DKMS. In fact, you know what we should do? We should have a donor registration camp of all of our friends, and whoever is interested can register as a stem cell donor. Yeah. So
Can
the
we do it as an online initiative where
yeah, we
the
can do it.
signature can be taken and things
Yeah,
like
yeah,
that?
yeah. It can. I mean, of course, what has to be done is the HLA, the kit, the buccal swab kit will be sent to your house. You take the swab, fill up the form, and you can also do it online. Put it in and courier it to the registry. If people are interested, then maybe we'll arrange a stem cell donor registration activity. It will be good fun.
Yeah, it will be a great fun. If you can share me the details, we can put it up during the conference when many of them will physically want to attend to take up the certificate. We
Yeah,
can create this initiative. Uh,
yeah, sure.
any more questions? We have a comment also. Wonderful class and a lot of new information. Thanks a lot. Thank you,
Pleasure.
Divya. So please unmute and ask.
Good information regarding stem cell transplantation, but we know a little bit of this earlier. But this HIV, receptor gene, this is a very interesting and new topic, sir. Thank you very
Absolutely.
much, sir.
In my mind, the best part of being a doctor is knowing biology. Yeah. It's just so fascinating.
True. And when you talk from your experience, I think that's where a lot of impact because we love to hear stories. So there are some comments. Excellent class, sir. Thank you all for active participation. Do share your case scenarios, even if
Yeah,
related to any of the earlier chapters. Sir
yeah.
has obliged to clarify all our doubts. Make use of this golden opportunity. Please attend the classes when he live stream so that you can interact well than taking a recorded session. Any more
And
Sir,
questions?
can I ask you one question regarding the case which recently posted, sir?
hmm, 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 hmm.
This is a
Yeah.
polycythemia. Somebody has asked it.
Hmm. Yeah,
Been above 18. So
yeah,
at that time, you responded saying that maintain the hydration very well and then repeat the CBC. And if it is still high, then we go accordingly as per the further investigation. That's what you mentioned.
yeah, yeah.
Suppose even after maintenance of hydration and a different lab also, we got the cross-checked it. If the hemoglobin is somewhere around 18, 19, and PCV is above 50, so immediately we have to do erythropoietin level and confirm, or what other things to be done, sir?
So we have to evaluate. So we have to evaluate for secondary polycythemia and polycythemia vera. So we do not only do the erythropoietin level, but we do a chest X-ray, we do echo, ECG. Sometimes there may be an occult cardiac problem, right, which has gone unnoticed. There may be COPD, smoking, which is causing secondary polycythemia. Yeah. Uh,
Or
then it
hormones, sir? Ladies on hormones
I
for
don't actually leads to that much high hemoglobin. I haven't seen. Maybe you've seen, but I haven't seen. It won't push it to that level. Uh, and progesterone and estrogen does not really stimulate erythropoiesis so much, right? Danazol does, but not progesterone and estrogen. The second bit, polycythemia vera, for that we do bone marrow examination, we do the mutations for myeloproliferative neoplasm, and very rarely we have congenital inherited causes of polycythemia, von Hippel-Lindau syndrome, erythropoietin receptor mutations, but that's rare. In my 20 years of hematology practice, I have about 5 patients with inherited polycythemia. So we have to rule out these things because the underlying disease may need treatment. And we can't just say, no, no, you donate blood, it will be okay. No. Maybe if it's a COPD and that person donates blood, it may not be good for the donor. If it is polycythemia vera, then that means that the marrow is not healthy. It's not safe blood for the recipient. So high hemoglobin, once you have repeated after adequate hydration, and adequate hydration means what? You tell them tomorrow you drink 1 liter water and come and do your hemoglobin. That's it. 1 liter water, 2, 3 hours later, you do your hemoglobin. That's it. And if that is still high, you should evaluate. You can't just donate because the donation may not be safe and the blood may not be safe. If we choose to do phlebotomy and reduce HB, then that blood has to be discarded. That can't be given to another human being.
But even this phlebotomy is done in a hospital or in the blood bank, sir?
Blood bank. A hospital can't do the for
in blood
phlebotomy, the bag of
transfusion.
blood, which is used in the blood bank, that is only
Area.
sold to blood banks. It is not even sold to hospitals which don't have blood bank. It has to be done in a blood bank, but that unit of blood is discarded. It can't be transfused to somebody else.
Sir, why, sir?
So polycythemia vera is a myeloproliferative neoplasm. It's a pre-malignant condition. About 8 to 20% of polycythemia patients may develop to acute myeloid leukemia later. You don't want to give a pre-malignant blood to the recipient.
Yes, sir. Thank you, sir.
Okay, guys. I think
Sir,
I'll also.
Thank you very much, sir.
Yeah,
question,
go
sir.
ahead. Yeah. Yeah.
After blood transfusion, if any like severe anemia, if we give blood transfusion, immediately after that we can give iron infusion.
Yeah, sure. Why not? See,
Okay.
anything can be given with blood and later. So, for example, many times we don't mix one IV with another IV, but Blood is blood. Whatever injection you're going is going in the blood only. So you can even give blood and then IV parallel to it. I mean, of course, I'm only talking theoretically. So any injection can be given along with a transfusion of blood products.
Thank
But
you,
that's a
sir.
good practical question. Okay.
Okay, sir. Sir, you have
Sir,
saved the
sir,
recording,
sir,
no, sir?
sir,
They
I
want
have,
the recording.
I have saved it.
sir,
I have saved. Yeah.
sir, ferric cellulose maltose injection, sir, FCM, sir.
Yeah.
So that is 500 milligram and 1000 milligram will come, no, sir?
Yeah.
So 1000 milligram injection, how much hemoglobin it will raise, sir?
No, it's not like that. So,
Okay.
see, one, it is based on the weight. So, if I'm not
Yes.
mistaken, less than 40 kg, you give 500 milligram. More than 40 kg, you give 1 gram. The rise in hemoglobin will be 0.5 grams per week, no matter what you give. Whether you give
Okay.
oral iron or injectable 500, 1 gram, the marrow can only do that much production.
Okay.
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 The dose that we give, extra dose, so you may give, repeated injections to pack up the ferritin, the stores,
Yes, sir. Yes.
to pack up the store so that the HB does not drop again. But the
Okay.
increase, the rate of increase will be the same because that is the production capacity of the marrow.
Okay.
Sir, iron
So in
sucrose.
CKD patient also same, so sir?
CKD is different. CKD is a completely different scenario. What I told you was about iron deficiency. CKD, every patient is different, right? And that is why the guidelines which are there, the American Kidney Association guidelines are the best. That's what I refer to. The guidelines are not that you should expect so much increase. The guidelines are, if the increase is less than this, then you look at erythropoietin. Because every
Okay, sir.
patient is different. Some patients, now for example, if CKD is because of SLE, then
Sir.
SLE being an inflammatory disease, the inflammation will again suppress the marrow,
Okay, sir.
right? So its CKD is quite different.
Okay.
And
Okay.
iron
Thank you, sir.
sucrose you should not use. Nobody should use iron sucrose henceforth. I have had 3, 4 patients with severe anaphylaxis, and one child has died. It's an age-old medicine. We should not use it. Please use, most of the patients will benefit with just oral tablets. Livogen and all that is a few rupees per tablet. If you have to give injectable, then use polycarboxy maltose or maltoside. We should stop using iron sucrose. It's not a safe injection.
Okay. Okay, thanks.
All right, I have to join another meeting now. We'll catch up again next Thursday on 6th. Yeah?
Thank you, sir.
Thank you
Wonderful.
so much, sir. Good day,
Thank
sir.
you.
Thanks a lot, sir.
Pleasure. Bye. Thanks.